Okay, let's talk prescribing, one of our favorite topics when discussing hormone replacement therapy. And so, our goal is to match patient profiles to optimal hormone replacement protocols. We always want to be safe, effective for our patients, but one of the biggest things I can tell you is every patient needs. Here are our learning objectives for this session. Okay, let's begin with a quick overview of hormone therapies that we offer and that practices typically offer. So, estrogen is useful for many symptoms of perimenopause and menopause, including vasomotor symptoms, genitourinary syndrome of menopause, which can be some of the most bothersome, as well as improvement in hair, skin, and sometimes migraines. We also have progesterone, which must be combined with systemic estrogen in a patient who has an intact uterus. So you cannot use just estrogen alone in a patient with an intact uterus. You can't let that endometrial lining growth go unchecked. It needs a balance. And so that's why we give progesterone. But progesterone by itself can be helpful for brain fog, difficulty concentrating, sleep disturbances, or even off label for those with vasomotor symptoms and a contraindication to estrogen therapy. Testosterone can be great for low libido, muscle loss, decreased energy, and motivation. Although it's important to note there are no FDA approved formulations for use in females at this point. But when you use it at 1/10 the dose that's available for males, that is very effective for women. Selective estrogen receptor modulators can be used for persistent genitourinary syndrome of menopause, and DHEA can also be used very effectively in genitourinary syndrome of menopause. Remember, we talked about how DHEA is converted to vaginal estrogen and then can improve the vaginal epithelial lining and thicken that without actually giving the patient a hormonal therapy. How about compounded medications? This is a big controversy, but I do believe that compounding medications have a place for certain patients. We've been writing these medications for many years, and the reason being, we want the treatment that is best suited for our patient, whether that is a specific formulation, whether it's for cost, whether it's because our patient requires a non commercially available dose or is sensitive to some of the concomitant ingredients offered in traditional prescription medications. So, some pros are you get individualizing dosing, you have many options for delivery system, including you can have a sublingual tablet, rectal suppository, nasal spray, and it's great for those with allergies or intolerance to traditionally FDA approved therapy because these can be prepared without binders, fillers, dyes, preservatives, and adhesives. The cons are they're not FDA regulated, although the pharmacies that produce them certainly are. They don't require a proof of claim. They're not necessarily safer than FDA medications. And there's some concern that there could be lack of monitoring of adverse events, although we know that these are reported. So, as a reminder, there are three different forms of estrogen. Initially, estradiol, which is E2, is your strongest form and it is the most active form. But postmenopause, estrone or E1 takes over, and that also can be converted in the adipose tissue. So, remember what's happening in perimenopause. Your progesterone drops first, but then your estrogen becomes erratic. Your follicle stimulating hormone starts to rise because your hypothalamic pituitary axis doesn't recognize the estrogen. It doesn't sense it anymore. And so you have just erratic hormones that I liken to adolescence. This is one of the reasons that estrogen replacement can be so helpful for so many menopausal symptoms. But beyond the different types of estrogens, there are also different delivery systems. Not all estrogens are the same. Remember how we talked about oral estrogens have first passed through the liver and could increase your sex hormone binding globulin, your C reactive protein, and your triglycerides. Transdermal alternatives, on the other hand, like patches and creams, do not have a first pass effect. they bypass the liver. And typically, those are preferred and acceptable for patients with migraines, high blood pressure. And so keep in mind that if you are prescribing estrogen to a patient with an intact uterus, you also must prescribe what? Correct. Progesterone for that patient because you need endometrial protection. Here, I also like to point out DHEA, which is converted by our bodies into estrogen and androgens in the vaginal tissue. We're going to talk a little bit more about this later. So, what's the deal with contraception? Well, pregnancy is possible until menopause is reached. Remember, we talked about loop cycles and how you can have a piggyback cycle on top of another one, which can inadvertently lead to ovulation and pregnancy and can explain why fertility can be increased during the perimenopausal years. Contraception sometimes is the best option for premenopause or perimenopausal symptoms, including abnormal uterine bleeding for a patient who doesn't want to become pregnant. Remember that risk of twins we talked about? And is your patient a healthy, lean, non smoker in perimenopause? Low dose oral contraceptive pills could be acceptable in your patient. If your patient is a smoker, they have high blood pressure or a history of venous thromboembolism, you're probably going to want to treat them with progesterone only. Devices like IUDs and implants, they can provide long-term placement and prevent pregnancy and abnormal uterine bleeding. So how can you transition your patient off of contraception onto hormone replacement therapy? Well, you could theoretically continue it until your patient is about 52 to 55. But if your patient remains symptomatic, they need alternative hormone therapy. So when you transition them, their hot flashes may come back because oral contraceptives actually have a higher hormonal concentration than traditional hormone therapy that we think about. Progesterone indication. So, if your patient has a uterus and they're on estrogen, they have to be on progesterone. You can't leave that endometrial lining unchecked. Micronized progesterone is preferred because of the safety profile when comparing with synthetic progestogens. It's so interesting. Progestogens are not progesterone, they are not made equal. And the distinction here is critical. Despite widespread interchangeable use in the medical literature and often our clinical practice, synthetic progestogens differ fundamentally from progesterone that is identical to what your body makes. So that's what we refer to that term as bioidentical hormones. All that means is it looks like a hormone that your body naturally makes. Unlike natural progesterone, progestogens are often estrogenic. They like the estrogen alpha receptor. And this is the subtype of receptor that is associated most with carcinogenesis. You will also see progesterone prescribed continuously and cyclically. So let's look at that. So typically, you'll give your patient progesterone 100 to 300 milligrams at night. And you can use this alone for sleep predominant symptoms, or you can use this for accompanying symptoms. Okay, so you can treat your patient every night if you're doing it for sleep, or you can do it cyclically. For perimenopausal women, if you are just using progesterone for endometrial protection in conjunction with an estrogen, it is okay for you to do this 12 to 14 days a month. That allows for mimicking of the normal menstrual cycle. But for those of you who are using it for sleep or other symptoms, continuous use is recommended. Testosterone, again, this is off label for all females, and females should be given 1/10 of the dose that are used in men. This can give women improved sexual function, satisfying sexual event frequency, desire, arousal, orgasm, and responsiveness. It can improve their self image, reduce their sexual concerns, and is good for patients with hypoactive sexual desire disorder. It's interesting, there are no adverse events with physiologic testosterone use reported, but you could get adverse events with higher doses. And again, no currently approved FDA formulation here. And you cannot use labs for testosterone in women. You really have to treat the symptoms, they will not be helpful. Selective estrogen receptor modulators, I'd just like for you to know about these. The most common is Aspina, or you may have patients who are on additional medications following treatment for ER, PR, positive breast cancer. But I just like to mention this as knowing it is an alternative to act on vaginal tissue, and it also is approved for moderate to severe dyspareunia or pain with intercourse. For vasomotor symptoms, essentially you have three options. I like for providers to know both compounded and prescription. So here you'll see highlighted in blue is your compound option, and below that is your prescription available option to any local pharmacy. So you really have three options: a transdermal patch, a cream, a gel, or a ring. Any of these are great options for patients who are appropriate for treatment. And a key is lifestyle preference, and the best option is the one they'll be compliant with. As far as, so let's talk about patches first. So your patch, you can apply twice a week, and typically you'll change that out. Some patients do it once a week. We always tell you to alternate sites. For estrogen cream or gel, for a compounded version, you have biased. And so that is a combination of two estrogens. And so remember that it's either an 80-20 formulation of estriol, estradiol, or a 50-50 formulation of estriol to estradiol. So patients will apply that typically on their abdomen or their inner thigh. And then if they prefer to have a prescribed gel, you can find that also. The estrogen ring, there's only a prescription option available, and that is placed intravaginally and is typically replaced after 90 days. So if you have a patient who is familiar with a Nuva ring, this is a great opportunity for them to have menopausal treatment with a similar therapy. I always tell you, start low, go slow, increase gradually, and titrate to symptoms. You're going to be tired of hearing this, but if your patient is receiving estrogen, they have to be on progesterone or they have an intact uterus. There really is only one micronized progesterone capsule that is available through a traditional pharmacy, and that is Prometrium. You can get 100 or 200 milligram tablets at night. Typically, those are written for 12 to 14 days. The pharmacist is going to call you if you're prescribing this every night for sleep, because it's not typically how it's prescribed. So you can also use a compounding pharmacy for immediate release or sustained release. And I recommend starting this at 100 milligrams and titrating up as needed. This should always be taken at night. Sustained release may be more sedating. And progesterone may be prescribed continuously, particularly if it's being used for symptoms and not only for endometrial protection. So remember that. Genitourinary syndrome of menopause. If conservative treatments are insufficient, you may want to move to prescription treatment. So your first line is going to be DHEA. That's available as a compounded cream, as well as an insert called Intrarosa, and that can be sent to a local pharmacy. This is very costly for patients. If symptoms persist, you can add a localized vaginal estrogen, and that is available as a compounded cream that can be used daily for the first 2 weeks and then changed to twice weekly dosing. You can get this through a traditional pharmacy. You can also have this compounded. And then you can have a localized vaginal estrogen ring. The S ring is typically replaced every 90 days. And this vaginal ring is the case is lower dose and provides only localized estrogen. So systemic progesterone does not have to be given with vaginal estrogen cream or with the S string. That's very important. You could also select Aspina, the selective estrogen receptor modulator, and that would have to be taken daily. So lots of good options here, and really is patient preference. Okay, progesterone can be most helpful if used by itself for the treatment of difficulty sleeping. Remember, we talked about changes in progesterone occur before changes in estrogen in patients who are in the menopausal transition. In these cases, if you're using it for sleep, it should be prescribed continuously. Compound options include progesterone immediate and sustained release, take it at night, and you can also prescribe prometrium to a local pharmacy if needed. It's important to dig into the causes of difficulty sleeping, make sure your patient isn't having hot flashes, and check them for additional stressors in their life, which can often lead to this. It's important that you provide comprehensive care for your patient. Decreased energy, libido, and muscle mass. This is off-label testosterone that's available as a compound and applied daily to the inner thigh, upper arm, or abdomen. It's also available as Testim gel at a local pharmacy. That medication, when prescribed, actually comes in large tubes and would last a man 30 days. But when a woman is using 1/10 of the dose, that will last her an entire year. When your patient is putting on testosterone, they have to be conscious about where they're putting it because you want to be careful about transference to other people, as well as potential for hirsutism in the area where you're applying it. For patients who report sexual dysfunction, low libido, it's important for you to diagnose the root cause. Is it truly decreased libido? Is it hypoorgasmia? Is it dyspareunia? And adjunctive therapies could also be helpful here in addition to testosterone. So, this is just a reminder of if your patient comes in and they are asking about hormone replacement therapy, or perhaps it comes up as part of your visit. Are they asymptomatic or are they symptomatic? If they're asymptomatic, take that opportunity to educate them about what symptoms look like. But if they're symptomatic, are they greater than 10 years out or less than 10 years out? If they're less than 10 years out, you want to talk about contraindications to therapy, absolute and relative. If there are some, talk about alternative treatment options. If there aren't any, then you're going to start to talk through symptoms for patients. And as you walk through symptoms, then you can appropriately treat your patient. Notice here, every box in blue is an option that's typically available at a compounding pharmacy, while options in gray are typically available at traditional pharmacies and can be e-scribed. So, in review, one of the easiest ways to treat your patients with hormone replacement therapy after you review the algorithm that we just talked about is to talk through their symptoms. Do they have poor sleep? They need progesterone. Low libido? Think about testosterone. Breast tenderness? You're going to lower your estrogen dose and ensure that you've optimized that patient's progesterone dosing. If they have breakthrough bleeding, you're going to refer them, and or you can check labs. Always think about osteoporosis prevention and support. If they have vaginal dryness, you're going to think about a vaginal estrogen or DHEA. And if they have anxiety, you're going to think about a low dose progesterone. Symptom-based titration, I always recommend a monthly visit with your patient to discuss response to therapy and communicating with them regularly. Annually, you want to review healthcare maintenance, talk about their mammogram. If they develop abnormal uterine bleeding without an obvious cause, so they haven't missed any progesterone doses, then they need referral. You really should not need routine hormonal serum lab testing. And the reason is if it's not going to guide your clinical decision making, you don't need to check it just to chase labs. You need to treat your patient that's in front of you for symptoms. You may want to check testosterone levels in patients, although again, not really recommended. If you do, I recommend waiting 6 weeks after initiation of your treatment and every 6 months after that if it gives your patient greater comfort. The most important thing here is you have to have shared decision making. This is so important for patients. Documentation with these patients is vital. You must document their body mass index, any medical changes, any immediate family history changes, their last menstrual period, any health maintenance, adherence to treatment is so important. I can't tell you how many patients come to me and say, well, I forgot to put my patch on for 3 weeks. They have to be adherent or it's not going to help them. Any current symptoms they have, any side effects, any lab work, document consent and discuss that and make sure that you have that in your chart. Talk about any dosing adjustments and next visit follow-up, set expectations. Lab monitoring, again, if your patient requests labs, you can check those. but really you're treating to symptoms. You want to follow up labs based on medication and route of administration and check hormone levels if needed. Really, urinary and salivary hormonal assays are unreliable, and as a general rule, I do not recommend checking these in your patients. And adjustments and tapering. So, when should you stop hormone therapy? Well, this also is shared decision making between your patient and you as the provider. 50% of patients have a recurrence of symptoms when they stop, and 20% of women have vasomotor symptoms. Interestingly, after you stop your estrogen, your bone density also decreases. So, you have to titrate your estrogen and testosterone dosing down. Do not stop abruptly. Make sure your patient is receiving their healthcare maintenance that's needed. Reassess therapy regularly and document any rationale for any changes that you make. Preventive care integration, I can't preach this enough. You have to use this not only to adequately take care of your patient, but also for your clinical precision. So, integrating preventive care strengthens overall outcomes. Make sure that you're asking about their bone density. You might want to review that. Ask about cardiovascular risk factors proactively, screen for mood and cognitive changes, and ensure that all of their cancer screenings are up to date. And so, some key takeaways for us for today: tailor your route, dose, and combination to your patient's goal and their safety profile. Look and refer back to this lecture and this algorithm as many times as you need to ensure that you are adequately prescribing your patient. Transdermal estrogen is preferred for women with high risk factors. If you don't have a uterus, what else do you use? Or what can you use? Estrogen. What if you have a uterus? Good, you need estrogen and progesterone. Local genitourinary syndrome of menopause therapies are effective and safe for almost all patients, even if they have a history of breast cancer. Local therapy alone is not going to address systemic symptoms. This is very important. But remember, if you are only on local therapy, vaginal estrogen, you do not have to be concurrently treated with progesterone for uterine safety. Early, frequent contact improves outcomes and adherence. So, talk to your patients often. Ask what questions they have. And I often recommend symptom diaries for patients. It's a helpful tool for follow up for me, but also for them. And so I'll just say, take note every day of how you're feeling. Thank y'all so